And we're rolling.
Okay, so first of all, Kim, if we could have your full name, who you are, what you do.
Kimberly Popovits. I'm the chairman and president of Genomic Health.
Okay, and if you could remember to look at me rather than at the camera. So first of all, where are we in personalised medicine? So in terms of breast cancer, in terms of prostate cancer, and bowel cancer, which I think you're also looking at. Just give us a roundup of what you're looking at in relation to those cancers.
Well, in some ways it's early days. Genomic Health was founded 15 years ago, and while that seems like a long time ago, we launched our first test in breast cancer in 2004, so it's just about 10 years old. And very pleased to be able to say today that that test is routinely used in clinical practice in the United States, and it's growing in acceptance worldwide. We have the majority of payers paying for it, so that assures patient access for the test. And would say that we have hugely changed the way breast cancer is treated. So early stage breast cancer, those are women diagnosed with stage 1 and 2 breast cancer, now have the opportunity to use our test to predict whether or not they should get chemotherapy. And we can demonstrate over this past decade that we've saved the healthcare system billions of dollars. We've helped over 500,000 patients now worldwide make that treatment decision. So it's been, when I think about the numbers of patients today and how the test is being adopted worldwide, I would say we've done very well in breast cancer.
How many women have actually had the test worldwide?
So worldwide we've served over 500,000 women with the test, the breast cancer test. Since that time, we've launched a test in colon cancer, a smaller population, and most recently we launched a test for prostate cancer.
Now, how can you tell over a longer period, because it is quite new, that decision, that medical decision at the time has been accurate not to use chemotherapy?
So this is where clinical evidence really matters, and one of the things I think we'll talk about for a long time in precision medicine or personalized medicine is how do we know when something's ready for prime time? And how do we know when something should be introduced routinely into clinical practice? And what we've seen clearly with the launch of our breast cancer test is that clinical evidence it makes a big difference, and you have to do multiple studies, the data has to be reproducible, and you then have to continue to demonstrate that treatment decisions are changing, and that the test, the quality of the test and the test accuracy continues to be developed over time.
So of those half a million women, it's quite hard, isn't it? I mean, how many of them went on to get a secondary cancer or metastases? How can you say that the test, how can you evaluate the test simply by saying, oh, you didn't need chemotherapy?
Right, so it starts with the development data and the clinical evidence, but those are retrospectively, the studies that are done with retrospective samples. What you do going forward, we do follow women prospectively, and there are 2 large studies ongoing right now. If you think about early stage cancers, and this is part of the dilemma, an early stage breast cancer patient, prostate cancer patient, or colon cancer patient is likely going to do very well with minimal invasive treatment. The problem we have is if we don't know which ones need more aggressive treatment, we tend to treat them all aggressively. And the numbers in early stage breast cancer are actually pretty shocking. When you think about the women that will benefit from chemotherapy in early stage breast cancer, it's actually only 4 in 100 women benefit from chemotherapy. So before launching our breast cancer test, more than 70% of women were getting treatment with chemotherapy for early stage breast cancer, yet we knew only 4 in 100 were benefiting. So the concept was, could we get closer to finding those 4 patients? We would spare the rest, the toxicities and the cost of getting chemotherapy, and get the drug to the right patients. That's what the breast cancer test does and the colon cancer test.
But are you able to show that by not having chemotherapy, they're not increasing the risk of getting a later cancer?
Yes, so we were able to demonstrate that in clinical studies. So when you look at the Oncotype DX breast cancer test, those women that have low recurrence scores, that's a recurrence score below 18, we can prove through the clinical data that their likelihood of recurrence is around 6.8%. What we also proved by doing more clinical work is that those women's, their cancers would not benefit from chemotherapy. Conversely, those patients that have a high recurrence score or we deem to be high risk, Not only do we know that their cancer has a likelihood of recurrence that's much higher, we also demonstrated through clinical studies that they get a huge benefit from chemotherapy. So essentially what we've done is we've turned chemotherapy into a targeted drug.
Is there a concern that it might be used to ration therapy as opposed to targeted?
Well, in terms of rationing therapy, what we have not seen yet a situation where payers have not allowed patients to make what we would call an individualized decision. And that really is what precision medicine or personalized medicine is. It's a decision that you're making around the treatment of your individual disease, having all of the relevant information in front of you. And what we can safely say today is if a woman is making a decision around whether or not to get chemotherapy and they've got early stage breast cancer, they are not making a good decision if they don't have the recurrence score in front of them. It is the most powerful piece of information that a patient can have, in addition to other information such as their tumor grade, their tumor size, their family history. But there's not any piece of information today that is more powerful in predicting the response to chemotherapy than the Oncotype DX recurrence score.
Is it possible to take a look at these 500,000 women and sort of look at survival rates or anything like that, which gives us in the media something very simple and substantial?
Yes, so we have a couple of studies that are ongoing. This was actually interesting because the NCI approached us to say we really would like to look at this long term. So recall earlier when we talked about most of these women are unlikely to have a recurrence. So if you're trying to follow this population to get to the endpoint of disease recurrence or survival, you'll be waiting a long time to do that, right? So it's going to take 10 to 20 years. But in fact, we embarked upon that study many years ago with the NCI, and we expect to see the first readout of that data sometime late 2016, 2017. So there's that study underway. And we also did a study with a German study group where we're following a group of women that have had recurrence scores, have made a treatment decision based on those recurrence scores to follow them closely over time to see the progression or lack thereof of their disease.
And these are over the German and the NCI over what period of time?
So the studies they'll take 10 to 15 years to mature because you'll be waiting that long to see the events. And that's why it takes a long time to do these studies if you're not doing them retrospectively.
Right. The other thing I wanted to talk about is the whole idea of treatment being more of a screening, and the whole idea of liquid biopsies. Now, a biopsy, usually by the time you have a biopsy, people know that you have a tumour of some sort, or at least suspect it. So let's take it in stages. How does a liquid biopsy work, and what would it be useful for? What kind of cancers?
So there's a couple of ways to look at a liquid biopsy, and there's a couple of definitions of a liquid biopsy. So I would start by saying that we're focused on liquid biopsies for patients that have already been diagnosed with cancer, but their cancer needs to be followed or their treatment needs to be followed. So being diagnosed with in early stage cancer, you can use a tool like the Oncotype DX tools to decide whether or not you need aggressive treatment. But the next question comes in, is this treatment working for me? How do I know whether or not the drug that I just took is actually impacting my disease? And what happens today is patients will wait months and perhaps get a PET scan to figure out whether or not the tumor is shrinking. They may wait several months to figure out whether the therapy is working. What would really be transformational in the management of the therapeutics in cancer is to be able to really quickly tell whether or not a drug is working. An interesting statistic is that we will spend about $80 billion this year on cancer therapeutics. Targeted therapeutics in cancer, so the average cancer drug works about 20% of the time. So we're signing up from the get-go for a $60 billion loss. And what we're focused on now is, why can't we do better? If we can sequence a genome, we ought to be able to figure out more quickly if cancer therapies are working just by looking at what is happening with the cancer in the blood. And that's what we've been focusing on at Genomic Health now for almost 3 years. If we can do this, and we believe we can, we've presented some data to demonstrate that we've made a huge amount of progress here, we would be able to very quickly look at a patient's blood or urine and look to see if the tumor burden is elevated. And if it is, a couple of questions need to be asked. Is the drug not working? Does the patient not have the right dose of the drug? Should we switch to a completely different drug? So being able to do that real time would allow us to quickly move patients who don't have a lot of time to try different therapies onto a therapy that might work better for them.
What about in terms of screening? Will there ever come a stage? I mean, this is obviously about how the drug is already working on a tumour. What about an earlier stage? Would you ever get to a point, do you think? Can we envisage a point where we can screen for cancer?
The screening for cancer through the blood would certainly be, I think, maybe the holy grail to most, right? You'd love to be able to find it before it even gets to a phase where a tumor is even being developed. And do I think that that's possible? Sure, I think that's possible in time. If you look at where our healthcare resources are spent today in oncology, they're predominantly in the last few months or weeks of a patient's life. And the goal in making cancer a chronic disease is to really move the treatment back to predisposition for disease, preventative measures to avoid the disease, and earlier screening. And we've made progress in terms of earlier screening through things like mammography and other tools, but we've not gotten to the place where we've been able to do it just by looking at blood. And clearly, when this technology gets to the point that we believe it is today and can even get better in the future, we should be able to do that.
So in terms of all of these sort of diagnostics, are we looking at only, presumably you're looking at being able to treat people who are at a very early stage of cancer, not people who are at later stages of cancer? So is this first people who are having cancer for the first time patients, or who?
It's really a combination. So you want to be able to use the tools when a patient is newly diagnosed. And the way we would view the future looking, if a patient is diagnosed with cancer, let's say first diagnosis, early stage, you would envision that patient would get what we refer to as a baseline tumor profile. So what is the signature of your tumor? Let's look at your tumor genomically and genetically to figure out the signature, much like you might get a blood type for a patient. Then the key is, post the first treatment, continuing to monitor that patient to see how that's changing. So if a patient's disease becomes metastatic, something has changed in the tumor. So those cells that started misbehaving in the beginning, and we treated it with a drug that worked, something changed, and it's causing another disruption, and therefore the disease has recurred. What you want to be able to do is catch that process quickly. Then you would be avoiding really late stage cancers where there's little hope for patients because the cancer has progressed too far. So if we can catch it early, and we are catching it earlier today, and we can then monitor the treatment faster, then we should be able to prevent more patients' disease from progressing to very late stage cancer.
Why is it that it seems that breast cancer and the treatment of breast cancer has advanced so much more than other cancers?
That's a great question. You know, the breast cancer community is a very strong community. One of the things that we certainly see is the amount of research and the attention around breast cancer has been much higher in the past than some of the other cancers. Now, that's changing a bit. So you see areas like prostate cancer with a lot more focus there. I think breast cancer also became a cancer of interest because it was very clear that we were over-treating women that were early staged when they were diagnosed. And there was a great deal of interest. When we started Genomic Health and we went out and talked to oncologists about what were their greatest needs in terms of their cancer patients, it was very clear that the question around how to treat women diagnosed with early stage breast cancer was a tough one, because they knew most women would do fine without chemotherapy, simply having their tumors removed, or perhaps a lumpectomy with radiation. But the chemotherapy question was always a tough one. That's why we started there. There's also a lot of studies that had already been done in breast cancer that allowed us to do the work that we were doing because tissue had been saved, and we had the cohorts of patients to go to with clinical outcomes data that we could match those patients to, that allowed us to do the work that we've been doing.
But there's been a lot of criticism that a lot of focus from research finance has gone into what has become the fashionable areas of health. Breast cancer has become one of them. And the argument is that other areas of cancer are being left aside simply because it's easier to catch up with ones that have already had the research done. I mean, is this all about breast cancer, prostate cancer? Are we talking about stretching these diagnostic tools to other cancers?
Well, we certainly have at Genomic Health. One of the things that was really clear in our mission when we started the company was that breast cancer was a starting point. We never wanted to be a single cancer company. It is a huge investment to do what we're doing. Starting out, we had to pick a cancer. Breast cancer was an obvious place to start, but our goal as a company was to be able to take the technology and the type of development that we were doing to all cancers and to all cancer patients worldwide. So that's why we moved into colon cancer and why since we've moved into prostate cancer.
When it comes to the liquid test or the blood test or the urine test, is that going to be connected to a specific cancer, or is it going to be trialed on other cancers?
It will be important as we develop the liquid biopsy that we pick a specific clinical question to address. And this is another thing that is really a core competency or I think value that Genomic Health can bring. To look at a cancer, and let's just say to sequence the genome of a particular cancer, but not be answering a specific clinical question, doesn't make it necessarily actionable in clinical practice. So what you need to do is you need to start with a clinical question. So we'll have to pick a cancer, whether it's breast cancer or bladder cancer, to develop the technology to prove that the liquid biopsy is actually telling us something meaningful for that cancer. But once that platform is developed and we can answer a clinical question in one cancer, it should fairly easily be transferable to answer similar questions in other cancers. So like the Oncotype DX platform that we've already developed, our intention for the liquid biopsy would be to start with a clinical question in a particular cancer and then move quickly to other cancers and other important questions that patients are facing.
So you're saying that all these diagnostics can be spread across all cancers?
The technology can be spread across all cancers, but again, you have to do the clinical studies and the work. You can't just develop a platform that says we can measure tumor burden in blood and suggest that that's useful across every cancer. You'd have to actually look at those particular cancers and say we can measure tumor burden or we can measure the molecular profile in blood, but we have to be able to tell you what does that mean to you. So if we came to you and said we've looked at the molecular signature of your cancer in your blood, and we've determined that these three pathways are of interest, we'd have to tell you why are they of interest. Is there a drug that you should be looking towards because those pathways are of interest? If we can't tell you what to do with the information, it's unlikely that payers want to pay for it, and it's not really helping you, other than it's an interesting piece of information, but how do I use it?
That brings me on to another point, actually. I mean, there is, in the UK, but not just looking at the UK, across Europe, in the US there's a great deal of controversy about health. How is it delivered? Who pays for it? How do you get people to pay for it? Why would they want, why, is it a necessary step, the step you're introducing, in systems that are creaking and breaking down because they don't have enough cash? Is it this diagnostic test, is it something that's going to mainly be in private practice?
We certainly hope not. The burden of proof, though, is on us. So if we're going to introduce a liquid biopsy, just as when we introduced the Oncotype DX platform for breast cancer, colon cancer, and prostate cancer, we took it upon ourselves to demonstrate by doing multiple studies around the world that we in fact would change decision making with the test. So when I say that something needs to be actionable, we need to demonstrate to both the medical community and to the payer world that this will change something for the betterment of either the quality of healthcare, that it's cost effective or cost savings. And we have done that now worldwide for the Oncotype platform, and we would intend to do the same thing for the liquid biopsy platform.
How have you done it for the Oncotype?
We've done multiple studies with the Oncotype platform around the world. We can demonstrate in each of those studies, on average, treatment decisions are changing 30+% of the time. Payers love to see that so that they realize they're not using a diagnostic and nothing's changing. In fact, a lot's changing when the Oncotype test is being used. We can also demonstrate that we're reducing the amount of chemotherapy that's being used. So we've done a number of studies with payers to follow their populations that have used the Oncotype DX test in breast cancer, to look to see what's happening in terms of the decisions that are being made, but even more important, longer term, what's happening with chemotherapy use. So we're seeing reductions in chemotherapy use. There's been studies done here in the UK of 50 to 60%. So that's hugely impactful for payers, and of course, wonderful for patients that don't have to endure the toxicities of a drug that isn't working for them.
Okay, so what's the next stage then with the liquid biopsy?
The next stage with the liquid biopsy is to complete the larger studies that we're doing. We've done several proof of concept studies. We've presented data demonstrating that we can actually look at tumor in tissue, and upon recurrence of disease, we can take that blood from the patient and we're able to see the same signature in the blood that we saw in the original tumor. But importantly, we're seeing an almost identical signature. But when I say almost identical, this is what's important. When we're looking at the tumor in blood after it's progressed, we're actually seeing some changes, and they could appear to be small changes, but they're clues. So those changes are what would help a patient figure out, what's my next best guess? What's the next place I should be looking? Why is the drug I was on not working any longer? Where do I go? That's where we're headed next. It's a very exciting time for the field. When we talk about today precision medicine or personalized medicine, our feeling is that the conversation has really changed from 10 years ago, and that most would agree that this approach is what's going to transform the treatment of cancer and allow us to better allocate healthcare resources.
Do you think people will have the budget for it?
I think the budget will be there if we start reallocating the budget appropriately. So when you think of today about how disease is treated, we predominantly focus our resources on doing procedures and prescribing drugs. And what we believe needs to change is more of our healthcare focus and resource needs to go into better diagnosing disease up front. So today, less than 2% of our healthcare dollars are spent on the diagnosis of disease. So in some ways, we're taking a bit of a shotgun approach. We're treating diseases that we don't understand. Now that we have the technology and the tools to be able to look at disease at the molecular level, and cancer clearly is a molecular disease, we have to be able to do better. So if we could shift those resources into tools like Oncotype that can better diagnose a disease up front, spare patients the experience of high-cost drugs that aren't working for them, we really can make a difference in the treatment of cancer.
In order to make that actually work though in terms of health budgets, it needs to start at a really early stage. Mm-hmm. Once a patient is already in the mill of a healthcare system, money's being spent quite rapidly. Should medicine be more focused at an earlier stage? Isn't it easier for drug companies to get involved when there is something to do?
When you think about how drug development has typically worked or how we've approached disease, we tend to be doing things to treat disease when it has progressed further than where we ultimately would like. So I do believe that incentives need to be created in the system to look at how do we catch disease earlier. Again, how do we diagnose disease better, faster? How do we stop one-size-fits-all treatment? And the way to do it is through diagnostic tools. And there has to be greater incentives going forward for companies to invest in the development of these types of tools. And that's not been there in our system. So when you think about the diagnostics world, and Genomic Health is a great example. We clearly are a pioneer in the field, but when we set out 15 years ago to develop the breast cancer test, nobody would have dreamed that you would spend $100+ million to develop that test and get it into clinical practice, and that it would take 10 years for payers to pay for it across the world. But that's the way the diagnostics world has worked, and we have to change that. And we're very excited that we're, I would say, the leader in doing this, but there's so much more work to be done. Doing things like Oncotype DX and other cancers has been a focus of ours for the last 10 years, but going forward, it's really into this, let's do it in blood, let's find the way to do a liquid biopsy and really monitor disease and make a difference for the journey for the cancer patient.
So for each patient, can we bring it down to something really simple? How much extra money does it take, say, a health authority or a country facing something like 1 million patients, various different types of cancer, I know breast cancer particularly. So how much more of a budget are we looking for then? Are you looking at adding to it by 10%, 5%?
Well, we may not be adding to the budget at all. So if you take the example of breast cancer, if you think about chemotherapy costing, and I'll use some US dollars here, but let's say chemotherapy can cost anywhere from $15,000 to $40,000. Radiation for breast cancer, $20,000 to $40,000. Take that relative to a test that's several $1,000s. And if you can actually avoid chemotherapy in 50% of the population that you were treating it in, and you can pick any number there, it's pretty easy to get to a cost savings formula fast. And that's what we believe needs to happen here. So same thing with a liquid biopsy. If we can tell a patient in 2 weeks that $100,000 targeted therapeutic isn't working for them and we need to switch them to something else, that should save the healthcare system a lot of money. But that work has to be done, and those formulas have to be created, and we have to prove that we're doing that. And we have done it with the Oncotype DX platform in breast and colon cancer, and we are working on doing that in prostate cancer as well now.
Is the Oncotype DX test is being used for breast cancer in health systems? Is the colon cancer one being used?
Yes, it is. So the colon cancer test is also available worldwide. It is to help colon cancer patients know whether or not their disease is aggressive, and by looking at the aggressiveness of disease, determining how aggressive should they be with their treatment.
So how widely used is that? How many patients have had that?
The breast cancer test is a much larger market, if you will. The colon cancer market is probably, I was going to say worldwide, maybe 60,000 patients or so between the U.S. and Europe. The U.S. alone is like 20,000 patients, so I guess it's probably twice that to maybe twice, a little bit more than twice that if you include the Western European markets.
Okay.
Do you want to do the last question again, because I heard a little alarm go off?
Yeah. So in terms of colon cancer, how it compares with breast cancer and how many people, how many patients have actually been treated using it and when it was introduced?
Right. The colon cancer test was introduced a few years after the breast cancer test. It's a much smaller market. In the U.S. alone, it's roughly 20,000 patients compared to breast cancer is more like 100,000 patients in the U.S. So smaller market, but an important question for those patients as well. They're diagnosed with early stage cancer. The question for them is, should they get really aggressive with their treatment? And the test helps them understand whether or not their cancer is aggressive and if they should have a more invasive treatment.
That's lovely, thank you.
Yeah.
If you could stop at that a little more closely.
Me to keep flipping?
No, I was saying, if you could you start again? So if you could start again, please, from the top.
From here?
Yeah, thanks. As if you're absorbing that information. And can we do it again, just from the...
Yeah, so
so if you go really close.
Sorry, 1 second.
So you see Kim's hand, but you don't, and more of the sheet.
More of the paper?
Yeah.
Okay.
Tell me when to go.
Yeah, go for it. So could you do that again and try and keep the paper on the desk? It's just a little hard to see it. If you put a few pages back,
Okay.
and yes, and as you were before, that's fine. I'm just focusing on the pages.
One more?
No, that's perfect.
Okay.
It's just to give us continuity, you see.
And go for it. And just one more time, sorry. And go for it.
Now what I want you to do there,
Mhm.
James, is to be able to, don't worry about the text, just the 2-block diagram. And Kim, if you could be sort of, when you naturally read, you naturally move just slightly. So if you could be looking at it, I know you've seen that a million times before.
Like a bobblehead.
Good.